And with that, we are at 12:05. I'm going to go ahead and get started. So thank you for my musings, my stylings of just taking time while we get started. So I'm Vanya Jones. Thank you all for joining today. I am the Assistant Dean for Community Engaged Research. I co-lead the Rural Health Initiative with Greg Kirk. I saw Greg earlier, who is our Vice Dean for Research at the Bloomberg School of Public Health at Johns Hopkins. You can find more information about the Rural Health Initiative and the work that we do and the aims to highlight public health research approaches and topics in rural health. Please mute yourself. We're going to have Junie drop the link for rural health. Thank you, Junie. You're probably aware of the research funding between JHU and WVU that was recently announced at both of our schools. So Junie is going to drop the link for both of those announcements for us in the chat. We anticipate that the details about application submissions will come later in this summer. So more to come. Loving the anticipation already of all the stuff we're doing. Rural Health Convos was created in response to this research opportunity, and our discussions between JHU and WVU investigators meant to highlight important topic areas of overlap and opportunity between the BSPH and WVU researchers. If you're registered for this webinar, we have added your name to a Google Sheet. So this is our second time doing this. We're trying something a little different. If you joined us last time, we have your name, but we've done it again. When you have a moment, we ask that you fill in your name. We put your email address. So go to the Google Sheet, find your email address, put your name in your area of interest. And if time permits at this discussion, at the end, we will hopefully have some opportunities for individuals to be able to put give an overview of some of their interests. So I think this is Junie. Is this you, Junie, sharing your screen so folks can see the Google Sheet? So this is the Google Sheet that we pre-populated with your email address. Go ahead and find it. One of the feedbacks we got the last time we did this is that folks were writing over folks in lines, and so we tried to minimize that. If you do not see your email address, go to the bottom. So unfortunately, we couldn't minimize it all because some of you may have just heard about this and decided to join us. Go to the bottom, add your email, and continue with the additional information. We also want to point out that if you have any other questions or you want to reach out to us, please email us at the Office of Research, bsph.research@jhu.edu, and we'll try to facilitate a conversation that way. We also want to highlight that at 1 p.m., the formal session will end, this discussion will end, but we invite you all to stay on and continue an informal discussion and opportunity to network with other investigators. This will not be included in the final recording. So if you stay on, we're not going to record it. It's just here for you to have a conversation. Our conversation today will explore the idea of social prescriptions and will largely focus on the idea that much of the work required to achieve health goals happens outside the clinic. So our BSPH events page that talks about this, Junie's going to drop that into the chat, as well as the WVU events page. Lastly, before we jump into our discussion today, I'd also like to invite you to join us for an additional rural health conversation taking place Monday, August 3rd. I'll repeat that. That's Monday, August 3rd from 11:30 to 12:30. That will explore rural health infrastructure and will feature a case study on cardiovascular health and pregnancy. You can find more about this particular conversation as Junie drops the information in the chat. Friends, are we ready for today? Because I am very excited to talk about to introduce what we're going to do today. So first, I'd like to thank our amazing panelists who have joined us today. Your contributions to this series and this conversation is extremely valuable, and I think will lead a very rich conversation. So I have the pleasure of introducing who's here. First is Renee Johnson. She is a professor of mental health at the BSPH here at the Johns Hopkins Bloomberg School of Public Health. She uses social epidemiology and behavioral science methods to investigate injury, violence, substance use, and overdose prevention. She works with the Healthy Together program led by Area Health Education Centers West, lovingly referred to as AHEC West. Together, Healthy Together is funded by the Maryland Community Health Resources Commission through a Health Equity Resources communities, otherwise known as HERT grant. The purpose is to support implementation of programs to address health disparities and improve health outcomes. Next is Bree Shepard. Bree is a rural health researcher and program evaluator who serves as director of West Virginia AHEC, a program director for the Community Engagement Outreach Core of the West Virginia Clinical and Translational Science Institute, and an adjunct assistant professor in the Department of Social and Behavioral Sciences at the WVU School of Public Health. And then we round out our amazing all-star team with Corey Edmonds, a two-time graduate of the WVU School of Public Health, earning both MPH and MHA degrees. Come on, Corey, make us all look bad. Throughout his tenure at MLMC, Corey has advanced through roles including community health worker, community health program manager, gaining firsthand experience and addressing social determinants of health, both at the individual and community levels. For more information on the speaker background, Junie's going to drop a link for you to look at yourself, to contact and see this amazing all-star team. So I have the first of our first speakers. I get to turn it over to Bree. Bree, can you come off mute and share a little bit about your work and who you are?
Yeah, thank you so much, Vanya, and thank you all for having me today. That was a great introduction. I don't have a whole lot to add at the moment, but I am going to get us started and hopefully sharing the right screen. Do you all see my disclosures?
Yes, you are sharing the right screen, Bree.
Okay, perfect. So, as Vanya noted, I am Bree Shepard. I'm the director of the West Virginia Area Health Education Center. Just want to start with a couple of disclosures, and that I do not have any real or perceived conflicts of interest that I'm aware of. But I'm very, very excited to be talking about kind of social prescriptions today and what impacts health outside of the clinic, which we know, and then kind of just tell a story. I want to start with a few definitions though. So what are social prescriptions? You can see it's really kind of referrals and navigations to services happening outside of the clinic. It's connecting patients with community services for things such as transportation, nutrition, translation services. And they're really designed to help address social determinants of health and health-related social needs. So social determinants of health are those conditions in which people are born, grow, live, work, and age. And you can kind of review there some of the main domains for that, but they all impact health in different ways, depending upon where you live, particularly in rural areas, which is kind of the focus for today. I do want to make a quick note of the term social drivers of health. This is sometimes used interchangeably with social determinants of health, and there was some work that came out of Southwest Virginia, where I'm originally from, where community members really were preferring the term social drivers of health, in that, determinants was kind of a fatalistic viewpoint, and it is what it is, kind of predetermined, whereas drivers helped them to feel a little bit more empowered, that there were things that they could do as part of their community and with their community to really influence some of those different factors that we know affect health. And then health-related social needs is another term-related concept. This is one that's used by the Center for Medicare and Medicaid as part of their Accountable Health Communities demonstration project, which I'm going to talk a little bit about here shortly. But really similar types of things, core needs that are upstream drivers of health, including housing instability, transportation and utility difficulties, etc. And then for folks who may not be familiar with area health education centers, these AHECs, as we lovingly call them, were actually created by Congress in the early 1970s as statewide healthcare workforce development programs to help assure that there would be a well-trained, consistent workforce, particularly emphasizing medically underserved and rural communities in each different state. So really the mission of the West Virginia AHEC is to improve the health of our communities by really helping to identify and develop that interprofessional workforce who are passionate about serving rural and medically underserved communities in our state. AHECs have similar missions across the country. So what do AHECs do? As I said, we are a healthcare workforce development program. We work in kind of three main spaces. I like to say we do healthcare careers exploration for high school students. So really letting them know what's out there and what they can be doing in their community, and giving them opportunities to explore what career they might want, but also opportunities like shadowing and what have you, research to make them more competitive for entry into different health profession schools as part of that. We do community-based clinical and experiential training, so really immersing students so that they can understand the unique benefits and challenges, especially related to healthcare, that different rural communities face. And then continuing education for current healthcare providers. AHEC also covers our 8 core topic areas, and you'll notice that social determinants of health are one of those. And so these are all topics that we talk through with our AHEC students, that form kind of the basis of any curricula and training that we do with them. So it is a very core component, that social prescriptions idea of what AHECs do. But now I'm going to ask you to go back to 2017 with me, when I was reasonably fresh out of my postdoc and really getting into rural health research and community engaged work. The Accountable Health Communities was a quasi-experimental design, a demonstration project that the Centers for Medicare and Medicaid Services implemented to really try to understand the benefits and the return on investment of identifying those health-related social needs in clinical settings, and then providing direct navigation or at least information about how those health-related social needs could be addressed outside of the clinic walls between visits. So what you see here is just the map of the different demonstration projects in each one. So each state was allowed to have one. In some cases, it was a health system. In the case of West Virginia, it was actually a really great collaboration between Charleston Area Medical Center and WVU's hospital in terms of the hospital partners, and then lots of our federally qualified health centers, etc. So I want to just overview the AHC evaluation design a little bit. So the way that it kind of worked is, for emergency departments, labor and delivery, behavioral health and primary care, there were individuals who would get a validated screening tool asking them about any of those health-related social needs. Once, if they screened positive, in the case of the assistance group, they were randomized into either the intervention group, which received a personalized list of resources from their community and their surrounding community that could help address those needs that were identified during the screening process. And then the other intervention group received that same personalized resources tool, but also was paired with a patient navigator, provided either by that clinic or by the West Virginia Center for Excellence in Disabilities, who provided navigation services for us. And really the goal was to understand, does addressing those needs reduce emergency department visits and other kind of costs related to things that happen outside of the clinic. There was also an alignment track, in which case there was navigation services, but there were also community coalitions who came together to help create resources for health-related social needs that might not be in that community currently. So I just want to give you a quick overview of some of the main findings of this multi-year demonstration project. You can see kind of from each track, it saved money. Helping to provide those navigation services and using that social prescriptions kind of model reduced emergency department visits and related costs, and success. We were very excited about that. One of the exciting things that came out of for me as well, is it was an opportunity to really get to work with students of which that is how I met Corey. So Corey, when he did his MPH practicum with me, worked with me on the implementation of the Accountable Health Communities model in West Virginia. So I'm going to turn it over to Corey now and let him talk about his journey.
Thank you, Bree. So yeah, as Bree mentioned, I was a student at the WVU School of Public Health. I started my MPH in 2018. I started my practice-based experience with the Accountable Health Communities model in winter of 2020. So it ended right in the middle of start COVID. So everything got uprooted about halfway through, but it was a good experience. And I was happy to be able to work with Bree on that. But my experience was mostly screening people for this health-related social needs in the emergency department at Ruby Memorial Hospital there in Morgantown. And specifically from my portion of that experiment, it was a kind of a micro analysis. 56% of the needs that we screened for were resolved. 31% of those were still in progress at the time that we ended my part of the experiment and did the report, and then 13% were still unresolved at that time. Some just snapshots of other data. Predominantly, those were Medicaid enrollees. An average of 1.56 of those needs were identified per person in navigation. And the most prominent need was a lack of reliable transportation.
Oh my goodness.
And if you think of West Virginia and the geography, the topography of West Virginia, that makes a lot of sense. And transportation is one of the greatest barriers for people accessing healthcare and a lot of the other things that they need to have.
Corey, I've
Yeah.
had a few people chat me that they'd like you to speak up just a little bit, if possible.
Sure, sorry about that. But yeah, the Accountable Health Communities model was implementation was a huge, step in my learning journey. Prior to that, I had worked probably 13 plus years in healthcare at the bedside. And then after I graduated with my MPH at WVU, I started here at Mount Laurel Medical Center as a community health worker. And so I started to get that hands-on experience connecting people with those resources. And actually, shortly after I started here at Mount Laurel, we launched a community health resource van that we deployed into the community to connect people with resources, and we screened similarly using the Prepare tool for those resources. So that was successful, but also as we went along in 2022, I took over as a program manager of our community health programs here at Mount Laurel, and a little bit of background from Mount Laurel Medical Center. We're a federally qualified health center. We have 4 locations. We serve Western Maryland and North Central West Virginia. We offer primary care, behavioral health. We do have a lot of wraparound services such as transportation. We have insurance navigation. We have community pharmacy, on-site laboratory, things like that. So we try to make it as easy as possible for patients to be able to access healthcare and get all their needs taken care of in one convenient trip. Because research has shown that if people are able to get all those things taken care of conveniently, they're more likely to engage in healthcare on a consistent basis. Since that time in 2021, I went back to WVU. I got my master's in health administration. And I've since been able to leverage my experiences there, working in grants, management, business development, community development, marketing, and working in the community. So I have a lot of community appointments and everything that I work a part of as well. But I think most importantly in 2024, I was able to launch the Nourishing Neighbors Mobile Market and Resource Exchange. And this was a grant-funded program that used food as the centerpiece to screen for social determinants of health, social drivers of health. But it took the resource to people and met them in their community where they live, work, and play. And so we went around to different communities in Western Maryland. We took the food to them. We recognized that they needed food. So we got them out with food, and then we screened them for other social determinants of health while we had them out there. We were able to connect them with community partners while we had them there. And it's really been a successful program. The program is in its third year of operation now, and believed to be grant funded to the Appalachian Food Farm and Food Alliance from the Western American Food Council. So there's really been some great movement there. But then fast forward to where we're at now, the HERC grant and the Healthy Together program, Mountain Laurel is the primary care partner on that grant. And so we have multiple roles in that grant, but primarily as the primary care partner, we do distribute remote monitoring devices. These are blood pressure cuffs, glucose monitors, things like that. And it helps enhance connectivity to patients outside of the clinic. So we're able to monitor, some of their vital signs and things like that when they're not in the clinic. If they have transportation barriers and aren't able to come into the clinic all the time, we're able to manage those things and monitor them from afar, so we don't always have to have them in the clinic. But then also an interesting piece of this grant for us was that we were able to get a special exception from the Community Health Resource Commission to buy a transportation van. We have a fleet of these vehicles that we provide transportation to our patients free of cost. And that program is really supported by our 340B revenue through our pharmacy program and things like that. And so we're able to provide transportation free of cost for our patients. And really, we don't charge for it. So really that's, I don't want to call it draining our resources, but we have to figure out a way to sustain that and a way to continue to support that. And so as our fleet continues to age, we've struggled at times to find grants to replace those vehicles because a lot of capital grants don't pay for vehicles and things like that. And so the commission allowed us to purchase a vehicle with grant funds. We've put it out there, and I think as of the grant report that we submitted, I think last week, since it's been in service a little over a year, I think it's closing in on 1,000 transports completed. So that singular vehicle purchase really has been instrumental in supplementing our transportation ability for our patients and helping them to access care. So when we talk about social prescriptions and that practice, addressing the social needs is pivotal, and making sure that people, access healthcare consistently and their ability to have it be like one of them good. But with that, I think I will hand it over to Renee and let her talk a little bit more about the Healthy Together program and the HOOK grant.
Thanks, Corey. Okay, so I will get started. So Bree gave a great background about social prescriptions, social drivers of health, health-related social needs, and the AHEC program. And then Corey told you a bit about his work at Mountain Laurel Medical Center, a federally qualified health center. I am sort of bridging the two. I work with AHEC West. I am working on an evaluation of AHEC West's initiative called Healthy Together. And some of the work that Corey discussed is in partnership with Healthy Together. So Mountain Laurel Medical Center is a partner on the Healthy Together initiative. So what's AHEC West? It is in Western Maryland, and you see their service area over here. They serve Garrett, Allegheny, Washington, Frederick, and Carroll counties, as well as Mineral County, West Virginia. When you look at this part of Maryland, it's clear to see that that communities are sort of multi-state communities. You don't just live in Maryland, but you live in a border county and have lots of interactions and cultural similarities with people in the bordering West Virginia counties. So the mission of AHEC West is to improve access to and promote quality in healthcare through education and collaboration. Melissa Clark is the executive director. David Stewart is the operations director, and Lydia Yoder is the program coordinator. And Lydia is on our call today, so I hope that we can take a moment to welcome her and have her take part in this conversation. I am going to talk about Healthy Together, but I want to be very clear that this is work that Lydia is really leading and doing. So what's the purpose? The purpose of this grant is to address substance use disorder and overdose, obesity, and cardiovascular disease for rural residents in Allegheny and Garrett counties. It's funded through a Maryland Community Health Resources Commission grant, specifically Health Equity Resource Communities grant. The goals are, 1, to connect residents to local FQHCs, like Mountain Laurel Medical Center, where Corey works, for direct access to primary, specialty, and pharmacy care. And 2, bridge gaps to care by implementing SUD services, providing remote medical monitoring by community health workers and home visits. 3, administering street health care, and 4, creating social drivers of health linkages. This probably goes without saying, but for folks in rural areas, it's really hard to get around. You might have to go up a mountain and down a mountain. So things like remote medical monitoring enable people to stay healthy even when they can't get to the clinic. I wanted to just take a minute to talk a little bit about the values of the Healthy Together program. Sorry, let me just move this. So their motto is, we're all in this together. And I think that that really personifies how they go about health promotion. They have designed Healthy Together with the people of Western Maryland in mind. So some of their values are to provide support and services in a manner that restores dignity for vulnerable residents. It's really important to the Healthy Together team that they don't increase the stigma of being a low-income person in Western Maryland. They believe that people's well-being, not rates of death and disease, is the most important metric. They promote equity and ensure that limited resources are not a barrier to health and social well-being. They attend to residents' immediate needs, including lack of transportation, hunger, or limited access to food. And you can tell from the data that Bree presented that when you have this sort of approach, it pays off in terms of health. The Healthy Together partners are on the left, and that relates to a value of this initiative, and that is that organizations that serve Allegheny, Garrett counties and the surrounding area should work in partnership rather than compete with one another. So it could have been a situation where Allegheny went for a grant and Garrett went for a grant, and they sort of didn't work in lockstep with each other. But this is a way to do work that actually serves the people better. The team is very focused on sustaining these collaborative efforts for the long term. The idea is that this is not a 5-year project, but this is the way that health promotion happens in Western Maryland. And then finally, this last value here is about supporting residents no matter what door they walk through. The core of Healthy Together is that there's a system of opportunities to gather information, some screening information about social drivers of health. And then when you find out about a particular resident and what their needs might be, then refer them to the most appropriate agency. So that might be Mountain Laurel Medical Center if it's about need for taking care of your diabetes. It may be Garrett County Health Department if the people don't have food or need nutrition support. But the screening is designed so that no matter how you got there, they help you find where you are supposed to be. Okay, so we have talked a bit about social prescriptions today, and I just wanted to just give some examples of how this is working with the Healthy Together initiative. So one is transportation support, and Corey talked about this. His clinic, Mountain Laurel Medical Center, used grant dollars to purchase vehicles that the clinic could use to go get people and bring them to the clinic. Not a traditional expense in health promotion grants. Other examples of social prescriptions in the area of transportation support include things like vouchers for the purchase of tires or driver's education courses. And the rationale for spending the money in this way is that people need it, and we're prioritizing people's needs and people's well-being. Two, it broadens employment options, and it enables people to access healthcare services and things like grocery stores so that they can get the food that they need. Another aspect of Healthy Together is the focus on increasing access to healthcare, behavioral health, and medication. So what are some social prescriptions there? There is an opportunity to provide overdose prevention resources in the form of what's called possibility shops. So here, folks who need it can get wound care kits or drug testing kits, things that they might need to prevent overdose. But in the spirit of whatever the person needs, whatever door you walk through, we want to make sure that you've got what you need. You could go to a possibility shop and get a coat if it's cold out and you don't have a coat, or even help getting a telephone if you don't have a cellular phone and people might need to get in touch with you. So really central to effective rural health is this idea that whatever door you walk through, whatever agency you go to, they do whatever they can possibly do to help you get your needs met. There is also dental vouchers because some patients transition to Medicare and then lost dental coverage. Healthy Together is addressing hunger, physical activity, and nutrition. Some of the things that they are doing are ensuring that farmers markets are accessible to SNAP recipients so that you can use your vouchers at farmers markets and get fresh fruits and vegetables. And guess what? You're also supporting the community and eating food, healthy food that comes from your community. They're also working with local farms to supply meal boxes to residents in need. And there is a great set of food banks. They're really pleasant places to be. It's a bit like grocery shopping. And then finally, housing security. Residents can get assistance with security deposits or even money to secure housing or to maintain ownership of a home. So that's an example of some of the social prescriptions that's happening through Healthy Together. And because the purpose of this series of talks is about working together and developing grants, I just wanted to share a couple of ideas about skills needed for research in this area. One, I think these are innovative ways of doing health promotion, and I think there is a need for innovative evaluation. I think that AHEC West and West Virginia University would have an interest in collaborating on real-world / quasi-experimental design, policy evaluation, economic evaluation, really looking at the return on investment for addressing social drivers of health. I think I am going to leave it there, but would be happy to talk more. And I just wanted to see if Lydia had anything to add to that as the leader for Healthy Together in AHEC West. So welcome, Lydia. Feel free to come off mute and say hello.
Hello, everyone. Thank you so much, Renee. You did a great job talking about what we do. You covered most everything that we do here. And Bree, you did a fabulous job talking about what AHEC does. I love what we do here. My team of community health workers are just busy in the community, identifying those barriers through those needs assessments. And we are busy with delivering food boxes for people who need emergency resources to be able to connect those individuals. Also, prescription assistance is another huge need in our community. If individuals aren't able to afford their prescriptions, that can cause a lot of issues with being able to stay healthy and well also. So I think we basically touched about everything that we do. Again, our biggest goal is to listen to stories. We want to hear what the individuals in our communities are going through. Last year, there was a flood in our area that a lot of people were affected by. Even that increased the need in our community. Individuals who may have been okay before suddenly have lost so much in their home to be able to stay well. If you don't have a washer and a dryer, it's really hard to launder your clothes. Or now if you have mold in your home, that's an issue with your health as well. So we've been working with those individuals to connect them to the resources in the community as well. But listening, being a listening ear and able to connect them to all of our wonderful partners so that their utilities aren't getting shut off and they have housing stability to be able to stay not be as stressed about where they're going to live. Those are all interesting things that happen in the rural part of our counties here in Western Maryland. We don't have Uber. So when people like Corey get a van to be able to transport people, that's really important. And our buses don't go to a lot of different places. So individuals may not be able to get to their appointments or to be able to get to even the basic necessities if they don't have transportation available. So I'm happy to be on this call today. Thank you for doing such a great job, Corey and Renee and Bree, talking about what AHECs do and how we can serve our community. I appreciate you all.
Thank you, Lydia.
Lydia, thank you so much for joining us and for sharing your perspective. Renee, I love this idea that you threw out there around innovative ways to help evaluate the work that's being done with AHEC West and AHECs in general, Bree. I feel like Lydia's comment around like transportation access and the types of services lend themselves some unique social and behavioral sciences when it comes to doing evaluation. I also think there's an interesting narrative here that you brought up with your map, and I'm going to turn to Corey. And I know Corey is going to try a new microphone because he wants to make sure you can hear all of his amazing tips. But Corey, can you give us some insights on what it's like to work at that state border between Western Maryland and West Virginia? Can you share some of the interesting issues or uniqueness of working at a border like that?
It's a challenge on a daily basis. Can you hear me better now?
Yeah.
Okay.
Yes.
It's a challenge on a daily basis. Especially, I felt it more since I've moved on to the administrative side of things in the grant world, because Maryland is wonderful at taking the funds that it has and turning those around into public-facing grant programs like the HERT grant that we can take and use to serve the public. Whereas West Virginia doesn't do that quite the same. The grants and the funds they flow a little differently, and the resources aren't as plentiful in West Virginia. So we struggle, like we have our 3 Maryland locations and 1 West Virginia location, and we struggle consistently to find funding to operate, whether it's just operate our clinic in West Virginia versus the Maryland clinics. But we've also struggled to find funding to fund like our transportation, insurance navigation services, like any of our wraparound services that actually would help address these social prescriptions. The funding is not there, and if it is there, it's much more scarce. So funding is a big issue. And then I don't know what the issue would be, but collaboration seems to come more natural in our Maryland counties than it does in our West Virginia counties. When we venture off into Mineral in Preston County, we have our location in Preston County. We serve a lot of people in Mineral County. It's a little bit harder. I don't know if it's just because you're going across state lines and maybe that's not where our home base is, so it's harder for us to work there, but it's a little more challenging. But the issues are the same, no matter which side of the border you're on. And it's hard to address them no matter where you're at. The solutions look very much the same on each side of the border as well. It's just the resources that you're able to leverage to address them look vastly different. And I think that's where there may be room at the federal level. That's a much bigger picture story, but there may be room at the federal level to do a better job at that down the road. So.
Thanks, Corey. I appreciate you sort of talking about state differences as well as, the coordinated efforts federally. Bree, I'm going to turn to you if that's okay. One of the things that you talked about was sort of Corey and Corey's work coming into this space and training people to do this work. I think, while we're thinking about this partnership with between JHU and WVU, one of the things we need to think about is training. And can you talk a little bit about what are some of the opportunities or you think that might be really important as we think about training folks to work in rural communities, or this conversation that Corey was just sharing with us, this relationship between two states that are bordering in trying to do some similar efforts. Can you talk about training a little bit?
Yeah, I'd be happy to. So I think one opportunity that we have kind of cross-state collaboration, but even other partnering with your AHICs in your state or across the country is the opportunity to do that rural immersive learning. So in 2018, HRSA, who is our federal funder, created an AHIC Scholars Program. It is a 2-year enhanced curriculum that is designed to help better prepare health profession students for multiple disciplines to serve rural and medically underserved communities. And so kind of every AHEC in the country has a scholars program with similar goals. They all look a little bit different. So the way that our scholars program works is we try to identify issues and areas where students may not get a whole lot of training in their current health professions training program and the clinical side of things or the practicum side of things. Social determinants of health being one of those, and how to navigate that as a provider. So one of the things that we're actually rolling out this year, we've kind of done it in a less formalized way, Corey's experience being one of those. But how to be an advocate for patients as a provider, and then understanding advocacy at different systems levels as well. So to Corey's point about federally, what are some of the things that can be done to help support resources and sustainability of providing these types of services. So that's a training we're going to roll out more formally this year. Another one that we have done is training in clinical and translational science for our students and our scholars in particular. So this is in its 3rd year now, going into its 4th year, but we pair one of our scholars with a community-based partner, and they work together collaboratively to address an issue that's important to them using those different clinical and translational science techniques. So what we do on our side is give them that foundational knowledge, and then they work with those communities directly to provide data, come up with solutions. An interesting one that came out this last year was a social media campaign and an app for early screening of diabetes. Using changes in melatonin and skin. So it was, a need in the community. The scholar was a physician assistant student, really interested in it, and it came out with these solutions and working with this extension to then provide those individuals not just with that screening, that wide-based screening, but then connect them with a clinic if they needed to do any kind of follow-up with that. So plenty of opportunities, and we're always excited to see what our students do, because they're really amazing.
That's super exciting and really is inspirational, and bringing in new scholars and how we move this work forward. And I'm going to tie this in a little bit to something that Renee brought up, which is around this uniqueness of evaluation. And Renee, can you, given that you're working with AHEC West, can you share with us some of the strategies as an evaluator that you're using with this partnership with AHEC West?
Sure. Well, let's see. So first I'll start with what is required as part of the evaluation for the state is fairly routine. So they want to see numbers, how many people have we talked to, any change in disease rates. So that's happening. But what I think are the exciting areas of evaluation for Healthy Together is just this idea of storytelling. How do we embed telling the stories of the folks who've been impacted by this grant into the grant? So what we are planning into the evaluation. So what we are planning to do as we start year 3 of this program is in-depth interviews with providers from the different partners to just hear the story. How did it impact your life to have meal boxes or have an $800 voucher so that you could prevent your house from going into foreclosure? And then sort of using those stories to talk about how the intervention worked and why the intervention worked and for whom the intervention worked. What I would love to do, but I think this will be too much for an evaluation of this project, but a really nice idea to partner with Bree and colleagues at West Virginia is to do an economic evaluation of this approach. It is very clear to me that doing things like paying for a van at Mount Laurel Medical Center to ensure that people with diabetes can get to the clinic makes sense both for people and financial sense. Like if you were managing your own household, you would say, if we have a car, then we can, prevent our health problems from getting worse and needing to be hospitalized. But how do we do that? How do we demonstrate the economics and the return on investment? I think that is key. So I think that is a future grant that I would love to do. And then I also think it's important to do that because this can't just be a 5-year project. It needs to be a change in how we go about health promotion in this area of the country and beyond. So I think thinking about sustainability and evaluating this project and identifying ways to keep it going are critical. Thanks.
With my work in community engaged research, I think this is you're speaking my language, Renee. I was getting all excited over here, which leads me to before we open it up broadly, I want to turn back to Corey because in your narrative, it really is someone who's invested in this work in both as an administrator as well as a direct service provider. I think it's just really important to ask, can you share a little bit about what perspective you think people should consider when it comes with working in communities, particularly when it comes to working in rural communities? Can you give us some parting words that will help us think about what these partnerships and this work should look like?
Sure. So I think the biggest thing for me is A, expect the unexpected, but B, because it will happen, but B, be willing to listen and listen intently. So when I established Nourishing Neighbors, I didn't just go establish the program. Mountain Laurel had done food distributions in partnership with the Maryland Food Bank for probably 6 years prior to me arriving. And so it was a bunch of learned experiences listening to, a series of complicated experiences and, frustrations on behalf of the community, on behalf of our organization. And so it was really a collaborative effort on behalf of several stakeholders that came together. We pursued the grant, we built the program, and now it's in its third year of running, and it's out there delivering, fresh, locally grown produce to people who need it. It's connecting people with resources. And so I think I'm not saying it's perfect. It's not. We learned a lot in the first year, and I think the AFFA group has went and, put those lessons into practice. But yeah, expect the unexpected, listen intently, and take those things that you learn along the way and make changes along the way. Don't just expect your way to be it throughout the project. So
And I think, correct me if I'm wrong, Corey, and jump in, Lydia or Bree, but it was important to make sure people got food, but also that they didn't feel bad about being people who didn't have food. And there are ways to distribute food and have food banks that really increase the stigma, and the result of that is people not wanting to come to the clinic, not wanting to have anything to do with the health department. So that's critical, particularly given the culture of Western Maryland and West Virginia.
yeah, it was when we started Nourishing Neighbors, we noticed that a lot of people were hesitant to come to us and they would get in line and be really unsure about the entire experience. And so after the first couple of distributions, we made the switch. We were screening first and then having them go through, get their food and then do the resources. We found out they weren't engaging with resources. They were just getting their food box and running. And so we made the switch early on to have them go through, visit all the resources first. Then we would screen them, then have them get their food box and leave. So we made sure that they were heard, they had their other needs taken care of first. Then we screened to confirm those needs, and then we gave them their food and left, and then there's follow-up on the back end. So that was, I think, an important pivot that we made.
Thank you. We are 2 minutes to the end of time. This conversation just flew by so quickly. We did have a few people who wanted to share their ideas. We can have you share if you can hang on after these 2 minutes while I remind you that we're doing another conversation. I saw Liz Selvin dropped in the chat some of for folks at JHU, some of the resources that her center has. She is one of our next speakers that's going to be a part of our next seminar series or discussion. Let me rephrase that. On August 3rd from 11:30 to 12:30, we're going to have a conversation about rural health infrastructure with a focus on cardiovascular health and pregnancy. That's going to be the case study that we talked about. You can sign up using the links that we've dropped in the chat. I'm very thankful for our speakers, so I'm big round of applause to our three amazing speakers who were able to share the work that they're doing, think about collaborations across our institutions, specifically honing in on unique strategies in order to evaluate some of this work, which looks a little different when you step outside a clinic. And so really appreciate the work that Renee, Corey, and Bree brought to our conversation today.